Hello and welcome back to Dr. Show Cares. Today I'm going to be talking about one of my favorite topics, which is hormone replacement therapy. Now, just a quick provisor, these talks, I try to kind of keep them a bit bite-sized. It's impossible to talk about everything relating to hormone replacement therapy in a short session like we're going to have today. But I've just tried to make it into a myth busting guide to try and make the information accessible and bite sized. But of course, if you have any follow up questions, you can read more detail on the blog article. But of course, you can always send in your questions to me, Instagram, or all of our different social network platforms. Right, so let's get stuck in. So, hormone replacement therapy is one of the most controversial things I think that's happened in the last 20, 30 years with regards to women's health. And it's generated such mixed reactions. So, some people obviously praise it for its ability to really give women their lives back by reducing perimenopausal and menopausal symptoms. But then there's also been the fear around it causing certain illnesses, and there's a lot of confusion around. So today we're going to be dissecting common myths about HRT and really giving the most accurate or data-led knowledge so that you are empowered to have conversations with your own healthcare providers and make decisions around your own care. Right. So what is HRT? So HRT means hormone replacement therapy. It's replacing the hormones that are lost during the perimenopausal and menopausal period. Now, we've already had a conversation about perimenopause being that sort of transition from our normal reproductive cyclical change to the menopause, which is when the cyclical activity of monthly cycle has stopped. And that's obviously defined as 1 year of no periods. Now, what happens with the perimenopause? We talked about the hormones kind of almost having a up and down kind of decline towards the lower levels of estrogen. So there is a variability as the estrogen levels lower. It's not just like a linear line, it's more kind of zigzag as it gets lower. And that also means that symptoms can wax and wane, come and go. And so HRT is really the most efficient method for treating the crippling menopausal symptoms, and we talked about that in a previous talk. Things like hot flushes or temperature dysregulation, night sweats, mood disorders, sleep problems, and obviously brain fog as well, and the vaginal symptoms, and all the skin, hair symptoms that can occur with the perimenopause and in menopause. Right. So, as I've mentioned, the main hormone or the biological cause of the perimenopausal symptoms is estrogen deficiency. But as I said, we cannot talk about menopause care in isolation because there are other factors at play, which is the psychosocial interactions that can make the symptoms of the estrogen deficiency more pronounced. So, how I say is the mental load a woman carries can impact her experience and of the symptoms and complications of the perimenopause and menopause. Now, the estrogen that we use is natural, it's body identical, which means it's the same as what our body makes, and it's derived from yam, so it's estradiol. And it comes in various forms, so as a tablet, and then what we describe as transdermal, so via the skin, so patches, gels, sprays, and all of this is absorbed into the bloodstream, so we call it systemic HRT. So any HRT that is aimed at the entirety of the body. Now, this is in contrast to vaginal HRT, or what some may call localized HRT, which is given to the vagina. And it's very low risk indeed in that it doesn't go into the bloodstream, and it's primarily used to treat genitourinary syndrome of the menopause, which we'll talk about in a later session. Now, localized HRT, I think the consensus is quite clear that it's very safe, and most women can stay on vaginal HRT to deal with the symptoms of genitourinary syndrome of the menopause for life. But when it comes to systemic HRT, there are other considerations, and that's because many of the systemic symptoms of the menopause can improve as a woman adjusts to that change in life. And other things like lifestyle factors and things like exercise, eating well, nutrition, all of those things can, and psychological therapies and addressing mental load can all contribute to improving the symptoms. So women don't have to take HRT to manage the symptoms of the perimenopause and the menopause. However, for most women, it does become unbearable, and this is why systemic HRT can be very useful indeed. Now, moving on, progesterone is only given as part of HRT to counteract the effects of estrogen on the womb lining. And that's because the womb lining will grow without that progesterone. So for women that don't have a womb, they can have estrogen only HRT. And this is women whose wombs have been removed. And also women who we're sure don't have endometriosis. Now, the best option for this, and you know already from previous talk that one of my favorite contraceptive options is Mirena, and this is one of the reasons why, because it's a very good womb protection for HRT, and also obviously provides a contraceptive function and can also treat some of the gynecological complications of the menopause. Now, there are tablet or patch options for providing that progesterone component, and these can be synthetic, but there is a body identical progesterone called Utrogestan, which is considered to be the lowest risk progesterone because it's the same as, or similar, the same component as our body produces, the progesterone that our body produces. Another word for it is micronized progesterone, so you might have heard that instead of Utrogestan. Now, there are many reasons as to why a woman can choose different forms of progesterone as part of their HRT, and it all depends on their own needs, their lifestyle, their risks, what they need as for a bleeding pattern. Because whilst Utrogestan is great, it can also make you feel sleepy, so it should be taken at night. And for women who feeling that sleepy effect might be too much for them. Plus, also, sometimes Utrogestan doesn't always give the really sort of a consistent bleeding pattern. And for some women, that's too problematic, and they prefer their synthetic progesterones, which are more likely to give a more regular bleeding pattern. This is for the perimenopausal women who are still. Now, testosterone is not routinely prescribed, but it can be included in HRT primarily to address low sex drive. Now, I know that there are some women who get additional benefit with testosterone over and beyond the low sex drive. So many report an increased feeling of energy, but I would really be cautious with this because obviously testosterone also comes with its own risk and should be used with caution. But yeah, it's certainly an important part of some women's HRT treatment. Now, there are two types of HRT treatment: cyclical, sometimes called sequential, and continuous combined. Now, cyclical is primarily for the women who are still perimenopausal, so still having bleed and still having some endogenous estrogen cyclical function. So it tries to mimic that by giving daily estrogen, but giving progesterone for about half of the cycle in order to induce a monthly bleed. But there are other patterns to it. You can try and see if you can induce a bi-monthly bleed or a tri-monthly bleed if that works better for the woman. But some women really like to have their monthly bleed, and so cyclical HRT can work for them in that way. Now, continuous combined is usually for the women who no longer have periods, and then they can just have the progesterone and the HRT combined all day, every day, until they come off the HRT. Now, there are some conditions that can make HRT unsuitable, but I always steer clear away from absolutes because even with all these conditions, having a conversation with the woman about the risks and the benefits, and also with other professionals, can mean that we can still deliver HRT or HRT treatment if other methods have failed, and the quality of life is really poor for that woman because of the HRT symptoms. So certainly, probably the highest risk is women who have a current or previous estrogen-related cancer like breast or ovarian. For most of those women, usually we're very cautious and would say no. But as I say, with these things, there's no absolutes. But it would be unusual, and usually with much conversation with the woman and her oncologist on risks. Now, women with blood clotting disorders can usually safely have what we call transdermal estrogen, so not with tablets. And generally speaking, if a woman has had a previous heart attack or stroke and they are stable on treatment, and there's a conversation with their cardiologist, they again can have transdermal estrogen as long as they're aware of the risks and the benefits. Now, with liver disease, it's a more difficult conversation. Again, can be had depending on the level of the liver disease, but again, sometimes transdermal estrogen or transdermal routes can be an option for those women. Similarly, with migraine with aura, we would say that they can have transdermal estrogen. A very few small percentage still would prefer oral. And again, it's not an absolute no, but it's just risk conversations. Breastfeeding, because estrogen can affect milk production and can be passed on in milk. So usually it's a very conversation with the woman about the risks and benefits. And most of the time it's probably a hold off. But again, they're not usually absolute. And gallbladder disease, again, usually a transdermal route, and we would often have with women. Now, myths versus facts. So we're moving to the next section, which is addressing some of the myths around HRT. Okay, so the number one myth is that HRT causes breast and ovarian cancer. And this is really one of the biggest fears associated with HRT use. Now, taking estrogen only HRT, which is only appropriate for women with no residual womb tissue, as I've mentioned previously, does not increase risk of dying from breast cancer. And there's little to no increased risk of even getting breast cancer. But we cannot it's a very, very low risk indeed. And I cannot overemphasize that, because for those sorts of women who don't have a womb, really, you have very little to fear from estrogen with regards to your breast and ovarian cancer risk. Now, for women who have a womb and need estrogen and progesterone, there is a small increased risk of getting breast cancer, but it's really small indeed. It's about 4 to 8 in 1,000 extra women who have taken combined HRT for 5 years. Now, the longer you take HRT and the older you are, can increase that risk. But after stopping, the risk does drop and may in fact return to the level before treatment was started. It's also important to remember that most women who get breast cancer will not die from it. And there's not really strong evidence to suggest that even combined HRT increases the risk of dying from breast cancer. Now, there is a small increased risk of ovarian cancer, but this is even lower than the combined breast cancer risk. Now, the second big myth is that natural therapies are superior and safer than HRT. So I always try and challenge this by what people's definition of natural is. The estradiol that we give as part of HRT is body identical and natural. It is derived from yams, but it has also undergone a lot of scientific testing and is regulated. Now, bioidentical HRT products are not regulated, and so really you could be putting anything in your body. Depending on who's telling you. Obviously, there's some clinics where they are very high level knowledge on this, and they provide personalized bioidentical HRT. But the British Menopause Society does not support this. And I would encourage women to do their own research when seeking bioidentical HRT, because of the non-regulation in this industry. Whereas the traditional body identical HRT that we give is regulated, and therefore we know what we're giving you. and what effect it can have. And we can talk to you about risks and benefits very clearly indeed. Okay, now HRT results in weight gain. This is another big myth. And to be honest, there is no evidence to back up that connection. What we do know, though, is that perimenopause and menopause can cause an increase in weight gain or make it more difficult to lose weight because of the changes in estrogen. Because estrogen is sort of kind of responsible for that reduction in waistline and more hips for women. And therefore, as the estrogen declines, women might find that they're gaining weight around the midriff, abdominal area. And this is a direct result of estrogen deficiency, and then they may falsely attribute it to HRT. What does happen though is HRT can cause bloating and fluid retention, particularly for women who are progesterone sensitive, and therefore those women may then mistakenly assume that that's what's causing them to gain weight, but actually it's more of a side effect of the HRT, usually the progesterone. Now, another big myth is that HRT causes heart disease. HRT does not increase the risk of heart disease if it started within 5 to 10 years of menopause. In fact, it is protective against heart disease. It helps with reduction in production of bad cholesterol, and also for furring of the arteries by cholesterol, all of these which contribute to heart disease. In fact, because it is so protective, there is this concept of the window of opportunity during the perimenopause and the early years post-menopause, where women can benefit from reducing their lifelong cardiovascular risk with HRT treatment. So we're not quite at the point where we're recommending it to be used if there are no symptoms at all, purely for this reason. But if there are symptoms present, this is definitely one of the big benefits of HRT, because women are far more likely to die from heart disease than breast cancer. And this is why for the majority of women that have symptoms, the benefits of HRT usually outweigh the small risks, or is one of the reasons why. Starting HRT in your 60s or 70s, which is more than 10 years after usual age of menopause, may slightly increase the risk of destabilizing or worsening existing heart disease. Therefore, in those women, we have to have quite serious conversations about looking at their cardiovascular risk and managing that. And sometimes even it might be worth getting a cardiac review with a CTCA to look for any existing cardiovascular disease before starting HRT in those women. So it really is advisable to start as soon as you notice menopausal symptoms, because the earlier the better in terms of risk. So stroke risk is slightly higher in women who use combined HRT, although this is reduced by using transdermal routes rather than taking it via the mouth, and these risks are very small as well. Now, there's another myth that HRT can postpone menopause. It does not. It can make the symptoms more tolerable and potentially reverse the feeling of the symptoms that caused by the estrogen deficiency, but it's not changing the timeline of menopause. Menopause is unavoidable. It's the end point of every woman's reproductive journey, and that's something to be celebrated in its own right. Every part of a woman's reproductive journey is celebrated. So HRT can make that transition more tolerable, but it's not going to stop it. Now, another myth is that HRT should not be started at a young age. This cannot be further from the truth. We would strongly recommend that women who have early menopause or premature menopause should consider HRT, or women who have a surgical menopause below the age of 50 to consider HRT. And this is because these women are at the greatest risk of developing the complications of menopause, such as heart disease or osteoporosis, because they would have had a longer time period without enough estrogen. So usually for these women, we would say continue HRT until at least the natural age of menopause, but of course it can be continued for longer depending on their needs, and it would require regular or at least annual conversations with the health professional around those risks and benefits. Now, there's also a myth that HRT is less effective at preventing fractures than vitamin D and calcium supplementation. Now, vitamin D and calcium supplementation are absolutely necessary in the perimenopause and menopausal period because it contributes to improving bone health, but there is no evidence that it would improve the risk of getting a fracture. HRT is the preventative treatment for preventing fractures in women who have symptoms of the perimenopause or the menopause. It strengthens the bones, and the evidence is very, very clear that it does prevent fractures and bone health for the future. Right. There's also a myth that HRT causes blood clots. The truth is that um, oral HRT can increase your risk, very small, so about 2 in 1,000 for women who've used combined HRT orally for about 7 years. But transdermal HRT do not pose any additional danger. But of course, your background risk is higher if there are other risk factors like obesity or a pre-existing history of blood clots. But a transdermal HRT via the skin doesn't add to that risk, whilst oral HRT, in that category of patients, we would suggest transdermal HRT. Okay, now there's another myth that HRT can only be used briefly. Now, that is not true. HRT is a quality of life issue, as well as we've talked about some of the benefits for future bone health and future cardiovascular health. But it should be used for as long as necessary at the lowest dosage that's needed because there are small risks, as we've discussed. But it shouldn't be discontinued just on a matter of age. A conversation needs to be had with the woman about her risks, her benefits, mental load, her own views, her own risk tolerance, because it's different for different women based on their own personal history, their own personal experience. What's the bigger thing for them? So I have women who are in their 60s and are still taking their HRT because they need it. And of course, we talk about the risks on an annual basis, and they're well aware that their natural risk is increasing because their age is increasing, and we have these conversations, but we do everything that we can to mitigate those risks and keep the HRT at the lowest dose. But I will not impose my will on a woman. It is her choice. I am a portal, and we show them the benefits versus the risks, and it's the woman's decision really about what is best for her life. We are providing the information, and in fact all of the main menopause societies, including the British Menopause Society, don't recommend an age for stopping HRT. They recommend a conversation with the woman about the risks as the benefits. Right. So, in conclusion, like many medications and treatments, HRT has its own advantages and disadvantages, and it's very, very personalized. It's deeply personal to the woman, her history, her social context, her psychological context, and everything else that is going on in her life, her need for functionality, all of that. And so, it's important for a woman to be empowered with the information, to have information with a healthcare professional to discuss their own what's best for them with regards to managing this transition into perimenopause and eventually menopause with comfort and confidence. And as I say, there's more information on the website. Please feel free to send email or a direct message if you have any questions. Of course, I cannot answer any clinical information unless in consultation, but I can give you some advice to help redirect you to your medical health professional. As I say again, thank you for listening. This is Dr. Showcares. We'll see you next time. Bye bye.